Chapter 7 addresses the skeletal system, including the bones and joints. And when we talk about the skeletal system, we look at it as that strong framework um, that will allow the body to have a certain shape. Um, in order for the body to have this kind of shape, um, the skeletal system needs to be strong enough and able to not only to support but also to protect those areas in our body that are essential for our existence. In the overview of the lecture, we will look at the bones, describing their structure, the way that bones are growing, and different types of markings on the bones. We'll discuss different parts of the axial and appendicular skeleton, the disorders of the bones, joints, including types, disorders, and um, any type of repairs that we can make on the joints. And similar to other chapters, we'll discuss aging as it pertains to the skeletal system. Those are the learning objectives for this lecture. So we'll start by describing the bone functions. And it's more than one, as I was saying before. First and probably the most important one is the support, because the skeletal system will provide the shape and allows the body to maintain an erect posture, together with the muscles, of course. But based on the structure of the skeletal system, we are able to have this stand up straight position, and we are able to function against gravity. The second function will be the function of protection. And the skeletal system, parts of it, are able to protect those delicate structures as the brain or spinal cord or the organs that lay inside the thoracic cavity. The third function will be that of leverage. So muscles that attach to some of the bones will function as levers, and as a result of that, movement will be produced. Another function will be that of storage, and our bones are the warehouse, our storage place for calcium and phosphorus. We do store calcium as phosphorus all the time in our bones, while other mechanisms will remove calcium as phosphorus, and those particles, those microelements will be used in metabolic processes. And last function, which is very important too, is that of producing blood cells, and especially the red blood cells. The blood cell production takes place in what is called the red bone marrow. So let's look a little bit into the structure of the bone. And I'll start by saying that our body has approximately 206 bones, and they come in all kinds of shapes. They can be classified as long bones, short bones, and irregular bones. The prototype for the long bone will be the humerus, like in this image, or the femur, like in this one. And those, you can see that one is it's a real image, a real cut, longitudinal cut inside a femur bone. So when we describe the long bones, those will be solid structures. However, if you look at some areas of it, it may look a little bit more porous, while in other areas they become very much denser and will develop a canal inside. So for the long bones, we'll describe what is called a proximal part that is called epiphysis. In growing bones, and only in children, we'll have an intermediate part, and you can see it in here, this area, that is called metaphysis. And this one will disappear once this epiphyseal line, which is cartilage, will disappear as the body matures and becomes the body of an adult. You can see the epiphyseal lines, which are also called growing areas, growing lines over here, also in the femur. The other part in the middle, which is made out from a more dense type of bone, is called diaphysis. And inside this tunnel structure, we have what is called the medullary cavity that will contain the bone marrow. So if we describe the bones by their shape as long bones, short bones, and irregular, by looking at their type inside, how they are structured from a microscopic point of view, we classify them as compact bone tissue or spongy or cancellous type of bone. And you have a representation of both of them. Um, you can see this trabecular kind of um, full of air, like a sponge type of structure that is the cancellous bone. And this structure is typical for um, your irregular bones, your flat bones, like the scapula. Irregular bones are your vertebrae. And also at the epiphysis sides, um, both proximal and distal in the long bones. What is interesting is that the diaphysis will be made out of this type of bone. Can you see over here how dense it is? The trabecular structures that you see in the cancellous bone completely disappeared, and they are um, replaced by this type of very, very dense and compact, and that's why it's called compact type of bone. And you can see that even in those flat or irregular bones, because what you see here is the connection between the humerus and the scapula. You can see that the spongiest bone in here is covered on the outside by a layer of cortical bone that gives the bone a little bit more sturdiness. So let's look a little bit at the structure, the microscopic structure now of the cortical bone or the compact bone. It's actually makes up for 75% of all the bony structures in our body. The structural unit of the cortical bone is called an osteon and is represented here. And if you look at it, you see that you have a central canal that inside you will have the capillaries, arterioles and venules and lymphatic vessels that come and become distributed from the main artery of the bone. So those will run up and down throughout the entire structure of the bone, and around those blood vessels, around this central canal, you will have concentric rings of bone tissue, sturdy, very hard bone tissue. Now, those tiny dots that you see in here, those are the cells that we see in the bone structure. And if you remember from when we discussed tissues, we have a few types of bone cells. We have osteocytes, that osteo means a bone and cytes means cells, that they are the mature bone cells. And they are included in those tiny areas inside the lamellae. And the lamellae are those concentric rings. And we have also the osteoblasts, that they're not represented here, but osteoblasts are located in those areas that will function as repairing and bone forming areas. Because if you remember, osteoblasts are those cells that will be the young cells that they are creating bone, are creating the bone structure. They are secreting this matrix that is hard and makes up for the bone structure. And in order to remember the name of osteoblast, remember the mnemonic that blasts build. Now we have a different type of cell, also a third type, that is called osteoclasts. And those are large, they have a lot of, they are multinucleated, and they are involved in the process of reabsorption of the bone. That means that they will break down bone tissue whenever is needed, reshaping the structure of the bone. Now, the Haversian canal is also called the central canal, and if you look over here, you see that the Haversian canals, they are connected among each other horizontally by what is called Falkland canals, where the capillaries are anastomosing, and the term anastomosis means a joining or a combination, a connection between blood vessels. As opposed to the compact bone that we can found it in the diaphysis, we have the cancellous bone or the spongy bone that it's about 25% of the total structure of the bones in our body. It can be found at the end of the bones, and sometimes it may line the medullary marrow cavity, and it's made out of what is called trabeculae. Those trabecular separations or septum that you can see if you're looking at the picture. So those trabeculae will be aligned based on the line of stress. And a line of stress is where the load, the weight, will be loaded on a certain segment of that bone. You will see that calcium deposits and the way that our bones develop is very much related to how do we use that area of our body. So just to summarize again, we have the proximal and distal epiphyses that are made out of spongy type of bone, cancellous bone. In children, we have the epiphyseal line that allows for growing. It's a cartilaginous line that lies inside and separates two bony types of structure. But based on this cartilage, new bone will be added on both sides and will allow the bone to grow along with the process of growing that we see in a child. In the middle, we found what is called the diaphysis, and you can see how the structure of those two, the proximal and the middle part of the bone, is different. If the proximal one has this kind of spongious type of structure with trabeculae, with compact bone on the outside, covering the outside, the diaphysis is made out only of cortical bone, the tough bone, and includes inside the medullary canal with the yellow bone marrow. I'm gonna summarize again the cells. So we have what is called an osteoprogenitor cell or stem cell. And stem cells, you will hear this term a lot because stem cells means a cell that is able to become any type of cell. And probably you heard the theory around the stem cells and the fact that nowadays we can save stem cells from the umbilical cord and save them in banks similar to the blood banks and use them whenever they are needed. And you will say, okay, so how can I use the stem cells? A main function of a stem cells nowadays in medical field is to treat cerebral palsy. And I've seen some extremely good results with that. What's very interesting about the stem cells is that once transfused to a patient, and usually they will be transfused to the same person or to someone that is a first degree relative, they do have the ability to start flowing inside our bloodstream, and they are able to recognize injured areas, like injured brain areas, and they will deposit themselves in those areas of scarring or of tissue that is malfunctioning and underdeveloped, and they become the cell that is missing over there. In cerebral palsy children, there is a brain injury as a result of most of the time a traumatic birth and hypoxia, lack of oxygen during the process of birth. So the stem cells are able to find those areas in the brain, and through repeated transfusions, it doesn't happen overnight and it doesn't happen with one transfusion. Usually those treatments treatments may take up to a year with subsequent transfusions, those babies can recover and have incredible progress in terms of neurologic deficit. They will improve. Another way that we are using stem cells, um, we use them and they are just researching that. Uh, there are no well-established indications to use stem cell for that, but I know that they are studying it right now to treat myocardial infarctions and the scar tissue of the heart by using stem cells and seeing if those stem cells have the ability of repairing and replacing the injured heart muscle. So at the level of the bone, we'll have some cells that are very similar to the stem cells, but they look and they function as bone cells, and they are called osteoprogenitor. Like they will, they are able to become cells involved in the process of building bone. And we found those mainly at the inner layer of the periosteum. Periosteum is a tiny membrane that covers our bones everywhere. They can become, so those osteoprogenitor cells have the capability of becoming either osteoblasts or chondroblasts. So they can become young cells able to manufacture either cartilaginous matrix in chondroblasts or bone matrix as osteoblasts. So osteoblasts, they cannot divide anymore, and they will secrete a lot of collagen and glycoprotein that will make up for the matrix of the bone. And when they become old, they will transform into osteocytes. On the other hand, I was telling you about the osteoclasts, and those are large multinucleated cells that live in certain spaces of the bone that are called Hauschip's lacuna. And their main role is to repair, replace, remodel the bone when needed, and they're activated by what is called the parathyroid hormone. It's a hormone that is secreted from the parathyroid gland. This slide summarizes again the type of structure that the bone will have, and you can see that if we are taking a look at this and we enlarge under the microscope a tiny piece of this bone, we can see that very close to the medullary canal we have the artery, the nerve, and the vein, followed by a thin layer of spongious bone that is close to the medullary canal towards the inside of the bone, followed by a thick layer of compact bone. And you can see here the osteon as the unit of bone structure. And you can see on the outside that this structure has a tiny layer, a thin layer of periosteum. That's the membrane that covers the bone. Now, if we are taking another in-depth look at this only small part of the bone, we can see how it's made up of concentric rings of bone matrix. And inside those will have what is called lacuna, where the osteocytes, the mature cells, will sit. And if those are pictures, here you see a real image, a real microscopic image of the bone tissue. Now let's discuss a little bit about bone marrow. And we have two types of bone marrow. We have what is called the red bone marrow that is can be found inside the trabecular structures of the cancellous bone, the spongy bone. And the main function of the red bone marrow is to manufacture continuously red blood cells. And we have another type of marrow that is called yellow marrow, will be found inside the central cavities of the long bones in the medullary canal of diaphysis, and it's mainly made out of fat. Now, interesting that in very young children and in infants or newborns, there is no yellow marrow. Once we develop and we become teenagers, the red bone marrow becomes replaced by yellow bone marrow by the fat, and the red marrow stays only in the cancellous bones. Now let's talk about a few membranes that we can found at the level of the bone. We have on the outside periosteum. Peri means outside or surrounding, and is that membrane that we can found on the outside of every single bone, and it's very dense, and it's made out of connective tissue that is irregular. It's very strong, especially in children. And in children, because it's so thick, many times when a long bone is fractured, is has an aspect of what is called a green stick fracture, because the periosteum still keeps the parts of the fracture together. It looks like when you're trying to break a branch that is very, very green, you're kind of bending it. It's broken inside, but you do not completely break it like a dry one, because the outside bark that is green keeps it still together. And that's what happens in children, where periosteum is so thick, and it's supposed to be thick in children because the main function of the periosteum is to contribute and build new bone towards the inside. Now we have a second membrane that covers the inside of the cavity, the medullary cavity. Now this one is thin, and it's just a lining. Now both of them contain both osteoblasts and osteoclasts, because the blast will build the bone while the osteoclast needs to remodel and make it to reach the shape that it's needed for the function. So first question asks, which protein makes up a major component of the bone matrix? And the options are keratin, collagen, melanin, and calcium. The answer is the major component of the bone matrix is collagen. Calcium is a mineral. It's not a protein. Keratin and melanin, they are proteins, but they are not part of the bone matrix. We found them in the integumentary system. So let's discuss a little bit bone development and growth. We have um, every single bone in our body starts during the fetal ossification, fetal development as a hyaline cartilage. The conversion of that cartilage to bone represents the process of ossification, and usually that ossification starts around second or third month of embryonic life. During that time, the osteoclasts start to remove the cartilage and will be replaced. The space that is left behind by the cartilage removed will allow the osteoblasts to start depositing bone tissue and build the bone. So when we start to develop the bones, that will start as what is called primary ossification centers, and that's in the shaft of the long bones, especially, or in the middle of short or flat bones. And we have what is called secondary ossification centers that will start and develop bone at the ends of a long bone, as in the epiphyses, distal and proximal. The processes are two types. I was telling you that it starts by osteoclasts eating out the cartilage, and that's what is called the endochondral ossification process that happens in most of our bones. However, there is a second type of ossification that is called intramembranous, and it's typical for flat bones and for the skull, where due to the structure of those, the actual structure of those bones, we don't have a lot of space. They are pretty much, they have a large surface. They don't have a lot of thickness to themselves. So the whole ossification process is a result of building bone structure from the membranes that are covering those structures. Now, before I'm going into the bone remodeling process, I'm gonna just emphasize the importance of the epiphyseal plate, and that's because um, the epiphyseal plate is critical to be intact for the bone growing to be proper. Once a fracture happens in a child, it's essential for us to diagnose if an epiphyseal plate was not involved, because once broken, we may end up having an uneven grow at that level. Two sides in the same epiphyseal plate may start having different rhythms of grow because the vascular supply may be impaired while the epiphyseal plate is broken. So once the bone is formed, there will be a continuous process of bone remodeling. It happens throughout our life and it never stops. And it's actually an adaptation to stress, and that's very obvious for long bones. And you will ask me, how do we know that? Well, actually, we have proof, especially with the astronauts that are spending a lot of time in space because they are not exposed to gravity and they have that kind of floating type of existence most of the day. Their bodies, not their bones mainly, are not exposed to gravity and to the need of bearing weight or carrying weight or working against a certain weight. And when they come back to Earth, they have a hard time to readapt to the gravity and being able to walk properly or function properly, especially um, because they suffer from a certain atrophy of the muscles. And to prevent that, most of those space stations will have rooms where they simulate gravity, and the astronauts are supposed to spend a certain amount of time every day in those rooms by exercising in order to maintain the health of their bones and the muscles. So, along with the bone remodeling comes in the concept of calcium warehouse. So our bones are storing the calcium. So there is a constant supply of calcium for the body needs. 90% of the calcium in our body will be stored in the bones and not freely circulating in our blood. Um, However, those storages are highly hormonal dependent, and the hormone that will dictate if the calcium will be deposited or removed from the bones is the parathyroid hormone. Every single um, molecule of calcium in our body will be replaced at a certain point. And if we look at the infants, the rate of replacement, of calcium replacement is 100% per year. It means that every single molecule of calcium in the body of an infant will be replaced throughout 12 months. On the other hand, in adults, we have slower rates, and the older we get, the slower will be the rates of replacement. And when I say replacement, it means I'm removing a molecule and I'm replacing it with a new one. So in adults, this process of replacing it is only 18%. Now you understand that if I'm removing all the time, but I'm replacing only 18% of the calcium, now that will explain to you why adults and the older we get, why we suffer from osteoporosis more and more, because the replacement is decreased. Now, what will increase the process of replacement will be any type of weight-bearing exercises. Because the non-stress exercise will promote the calcium loss, the bone is not stressed. The bone needs a little bit of stress in order to be functional. So an exercise that is weight-bearing is walking, is aerobic exercising, is running and more like jogging, any kind of exercise that will use gravity. The non-stress ones, the example of an activity like that will be swimming, where water will kind of engulf the body, and there will be no specific stress on one part. The pressure of the water will be distributed the same way everywhere on the body. So for your patients that have osteoporosis, we need to encourage them to perform weight-bearing exercises. In the process of bone remodeling, nutrition is essential because if I'm not having enough calcium to support my metabolism, um, my body will continue to remove calcium from the bones and not replace them because I do not replace it by nutrition. And as a result of that, will develop all kind of bone-related deficiencies. In the process of remodeling of the bone, there are a few vitamins that are involved, and one of them is vitamin C that is needed for proper collagen formation. And your typical deficiency of vitamin C is called scurvy. Vitamin A is also essential, and vitamin D is the one that is um, totally necessary um, for the calcium to be able to be deposited in a proper way in the bones. The deficiency of vitamin D, for whatever causes, it can be a deficiency in nutrition or not enough exposure to UV light. We need a little bit of exposure of UV light for the vitamin D to become active, because the form that we are ingesting is usually non-active, becomes active in our skin by exposure to UV light, just by being outside in the sun. And when I say outside in the sun, you don't need to be outside and burn yourself or tan to have enough UV light. Just going outside while being dressed, just by exposing hands and face and neck, it's enough um, to synthesize enough vitamin D that is activated. The deficiency of vitamin D develops into a condition that is called rickets. Um, in the process of bone growing and remodeling, if we are looking into height of a patient or of an individual, that is genetically coded. However, whenever there is a detrimental nutrition and the organism is in a growing um, type of cycle, the height will be stunned. Without proper nutrition, no matter what the genetics say, the individual will not gonna reach its potential. Each bone has also a blood supply. The bigger the bone, the more important and bigger will be the artery that will supply that bone. And you can see that it says a high supply because it takes up to 400 milliliter per minute just to the bones in terms of blood flow. And the blood supply comes from what is called the nutrient artery that will penetrate the bone, will enter the bone at the level of the aphysis and will um, spread and distribute to the marrow cavities, epiphyseal regions, and metaphysis, becoming metaphyseal artery and epiphyseal artery. The bone tissue regulation, I was telling you, that is dependent on the parathyroid gland, especially the calcium. And it follows the same type of negative feedback. Whenever there is low plasma calcium levels, that will be observed and recognized by the parathyroid gland. As a result of that, the parathyroid gland will increase the secretion of the parathyroid hormone. The level of parathyroid hormone in the blood will increase and will stimulate at the level of the bone the activity of osteoclasts. Osteoclasts will remove more bone tissue, releasing calcium into the blood flow, and as a result of that will be a correction of the plasma calcium concentration in the blood. Bones can be injured, and an injury of a bone is called a fracture. Um, the healing of a normal bone may take up to 12 weeks. It's on average 8 to 12 weeks and takes place in 5 stages and is very similar to the healing of any other tissue in our body. However, it has a little bit of particularities when we are looking at the bone. As any breakage in a tissue will have the stage of inflammation. Blood vessels will be interrupted, will be broken. A little bit of blood, a little bit or a lot more than a little bit, will accumulate in the cavity where the fracture happens, and the hematoma will develop. And this stage is what happens 24 to 48 hours after the injury. This hematoma now is essential for the healing of the bone. It's necessary over there because together with the hematoma, the body already starts to develop a matrix, an incipient, an initial matrix to heal the bone. Starting around day 3 will be what is called, will start the process of cellular proliferation. Fibroblasts will invade that area and they will start to secrete collagen and fibrin, and they will start to develop the periosteal callus. Callus is that healing process that is specific for fractures. The cellular proliferation will continue with the callus formation up to 4 weeks, and now the collagen will be, the fibroblasts will be replaced by osteoblasts that will secrete more collagen, and that will become the ossification process by depositing in the collagen matrix, depositing calcium. The actual ossification is longer and may take up to 4 months, and during this process, the initial matrix will become sturdier and sturdier. After those 4 months, the process of remodeling starts. Now, the remodeling may start way earlier if we allow for stress on the bone. And this is the trick in being able to heal bones and maintain function of a limb very, very quick. Back in the day, we used to do one thing. We knew how to immobilize a segment that was injured. And by immobilizing it, we allowed the callus to form. The callus in stage C is still very unstable. It's just soft tissue. Is not enough, doesn't have enough calcium in it to be strong enough. And the bone that is supposed to a lot of stress without any kind of support at this stage may break again. However, because we know that it's so soft, we can do something else, and it's used in some orthopedic procedures for what is called elongations. We pull on a segment that it's shortened for whatever reasons. It can be a congenital condition when someone has one limb shortened than the other, and we want to bring them to the same length. At this stage, we can start pulling slowly, millimeters per day, and kind of extend and expand the length, kind of producing an artificial and accelerated growing process on that bone. Nowadays, we have a different way of looking at the fractures because we do what is called open reduction and internal fixation. Reduction is replacing to the original points where they need to be the fragments that were broken. Usually there are 2, but they can be more than 2 fragments that result from fracture, from breaking a bone. And we do what is called internal fixation by using plates and screws, rods inside the bones, or just screws sometimes are enough to keep those fragments together. Once we have this reinforcement that comes from the hardware, from plates and rods and screws, we can start physiotherapy with those patients as soon as a couple of days later. And the results are amazing because they are not going through the process of atrophy, and the remodeling and the ossification is accelerated because we are using the limb as opposed to just having it completely immobilized in a cast like we used to do back in the day. Together with the normal process of healing, we have some pathological bone healing. And we have what is called a distraction. In order for the bone to be able to heal, the two ends that were broken, they need to touch each other. They are not supposed to be intercalated to cover each other or to be too distracted to have no contact with each other. And this destruction may be as a result of the injury itself, or it may happen as complication of surgery that was performed incorrectly, or having an overcorrection during the surgery and not paying attention to the fact that the fragments are not touching each other. Whenever we have interposition of soft tissue, um, well, imagine that the bones are actually, they have around them muscles and fascias and other tissues. When a bone is broken, tiny parts of the muscle or the fascia may intercalate and may be positioned in between the fragments, the two fragments of the fracture, and that will prevent the formation of the hematoma and the development of the callus. We do have another type of pathological bone healing that is called avascular necrosis. Avascular means a without, vascular, blood flow. So necrosis means death of the tissue. The bone tissue will die and will replaced with nothing, literally will be completely absorbed by the body due to a lack of vascular supply. Whenever there is no blood supply to that area, to that part of the bone, it may be completely resorbed and disappear. Another process that may impair the process, another process that impair the process, oh my God, another element that can impair the process of healing is presence of infection. Um, and infections can contaminate the inside of the bone. Germs can contaminate the inside part of the bone whenever we have what is called a compound or open fractures. Those will be the fractures where the velocity of the injury is so high that fragments of the bone are so twisted that they will perforate and they will open the skin. And through that open wound, germs can get inside and populate the medullary cavity and prevent the normal healing. Another complication of a fracture is what is called a compartment syndrome. Muscles around the bones are contained in a very well-defined cavities that they are called compartments. And what keeps the muscles together is that very dense fibrotic connective tissue that is called the fascia. Um, and the muscles, whenever there is bleeding or an injury or edema of the structures, the muscles can become so inflamed and may swell up to a point where the swelling of the muscles can put pressure on the blood vessels and prevent them from staying open. And as a result of that, a compartment syndrome is created, and tissue death can happen from lack of blood supply. We may have another situation that is called a non-union, again, as an effect of infection or movement that breaks the callus in the process of healing. And non-union means that I have two very nice fragments that are close to each other, however, they are not connected at all. We may have what is called a delayed union, and that means that the healing takes way longer than what is expected to be in terms of weeks, and may be a result of osteoporosis or osteomalacia. We may have a malunion that we have two fragments that they are healed together, they are connected together. However, the bone is not healing. It's not, those two fragments do not fit the right way. There is some kind of torsion, like a twisting of the bone or an angling of the bone that prevents the bone from functioning properly in that area of the body. In terms of bone structure, we'll have something in addition to just the general shape of a bone. And this is called bone markings. And there are some distinguishing features on the surface of the bone. We may have what is called projection. And let's look at and describe a few of them. So we may have what is called a head. and that's usually a knob-like, kind of roundish end that is separated by the rest of the bone by what is called the neck. They will have kind of a slender region that will connect the head to the rest of the bone. Bones may have projections that are parts that are kind of standing out from the bone. We may have what is called the condyle, which is again a rounded projection um, that is seen mainly in the knees, and may have an additional projection on it. Is kind of a hump that has another hump on it. That is called an epicondyle, and epi again means on the outside. We may see crests, and that's kind of a border or a ridge that most of the time is rough, um, that provides insertion points for muscles. We may have a spine that is the sharp projection from a surface of a bone, like in the spine of the scapula. So if those are the bone markings that stand out from the bone, we have those that are depressions or holes inside the structure, and we have foramen. That's a hole that will allow vessels or nerves to go through or between the bones. We can see a sinus. That's a cavity or a hollow space, usually filled with air, like the sinuses that we have in the skull bones. We can see a fossa, and the fossa is a depression, like a tiny uh, kind of valley like this inside the bone surface. And we have what is called a meatus. That's a short canal or a passageway. That an example of that is the meatus, the canal in the temporal bone that goes to the inner ear. So question number 2 asks, where does bone growth occur in children? And the options are center of bone shafts, epiphyseal plates, medullary cavities, or epiphyseal lines. The answer is epiphyseal plates allow for bone growth in children. Center of bone shafts, it's not a bone growth place. It's where the process of ossification starts in an embryo. Medullary cavities will allow for a certain degree of replacement of bone, but definitely not bone growth. And epiphyseal lines are those places that will replace the epiphyseal plates once those become inactive. Let's discuss a little bit the differences between axial and appendicular skeleton. So again, we have 206 bones, and we can group them in two groups. We have the axial one made out of 80 bones, and if you look at the picture you see on your left side, you see the axial skeleton that is part of the middle, the framework of the body with the head and the trunk, and we have the appendicular skeleton that is made out of way more bones, 126 bones, and will give you the framework for the extremities. So the extremities in the appendicular skeleton, we have the extremity together with the belts that will connect those extremities to the body. Axial skeleton, again, 80 bones. We have 8 bones for the cranial. We have 14 bones for the facial area. So at the head level, we have altogether 22 different bones. We have one bone in the neck that is called hyoid. Please remember about hyoid, something that is very important, the fact that it's the only bone in our body that is not articulating itself with another bone. It kind of lives over there on itself, and it's connected just with muscles. Bones of the ear are 6, 3 on each side. Vertebral column, the spine will have 26, sternum is 1, and we have 24 ribs, 12 on each side. So we'll describe a little bit the bones, each of them. We have at the level of the cranium, we have 8 cranial bones, and they fit together in order to form a cavity that will enclose the brain, will be the house for the ear, and will form part of the eye socket. And I say only part of the eye socket because another part of it is made out of the facial bones. And regarding the cranial bones, we have the frontal bone that makes up for the forehead, the anterior skull's roof, and the roof of the eye orbit. At the level of the frontal bone, we have frontal sinuses that will communicate with the facial bones in the nasal cavity. We have 2 parietal bones that will make up for the top and sides of the cranium, 2 temporal bones on the sides, and will make up also for part of the base of the skull, and will have an occipital bone. Also, we have the ethmoid bone. Those are bones that are not visible from outside. If you will look inside your book, you will be able to observe them a little bit better. The ethmoid bone is very light and is located between the eyes in the back part of the eye sockets, and it has a shape of a butterfly. We have the sphenoid bone that is located also inside the cranium, and it has a depression on it that is called sella turcica, where the pituitary gland will sit. For the facial bones, those are, before I'm moving into the facial bones, just really quick, there are some sutures that we'll discuss them in a second when we'll we'll have another slide with a picture of the cranium. So facial bones will be 14. They will form the face and will host inside sensory organs. We have 1 mandible, that's your lower jaw. We have maxilla, that is made up of 2 parts. It comes from right and left sides and makes up for the upper jaw. We have zygomatic bones that are the prominences of your cheeks, nasal bones that make up for the bridge of the nose. Lacrimal bones are the are the medial walls of the orbital cavity immediately above the nasal bones and a little bit inside the eye socket. We have the vomer, that is the posterior part of the hard palate. We have the palatine bones, that there are 2 of them, and they are sutured. They meet together in the midline of the mouth. And we have the inferior nasal conchae. Before that, I was telling you that we have 3 ear bones that are all interconnected. They are called ossicles, and they are tiny, 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 the smallest ones in our body, and they vibrate and transmit sounds through the middle ear. At the level of the trunk, we have 26 vertebrae that will enclose the spinal cord, the sternum, and the ribs that will enclose the organs of the thorax. So I was telling you about the sutures. So we have what is called the coronal suture, and you can see it over here. And it's called coronal because it looks like a crown, where the crown was supposed to be, and will connect the frontal bone and the 2 parietal bone. We have a lambdoidal suture over here in the back, and it's called like that because it resembles the letter lambda from Greek, and connects the parietal bones with the occipital bone. We have the squamous suture that will connect your temporal and parietal bones, and we have the sagittal suture that is kind of hard to see here because it's in the middle of the skull and goes anterior to posterior and connects. It's over here and connects the 2 parietal bones. This is a quick image from like a bird view for the sutures, and you can see here the skull of an adult on the left side, and you can see all the sutures that were harder to present in the previous one. This is the coronal one, frontal to the two parietal bones. The suture between the sagittal one between the two parietal bones, and the lambdoid suture between the occipital bone and the two parietal bones. Now look at the infant skull, and you can see that there are some gaps that are replaced by membranes, not by cartilaginous tissue, but by pure membranes that will connect those bones. And if you see the way that all those areas, you can see how the bones are not connected with each other in a baby. And now you understand how by being not connected and just having membranes, the baby's head can be what is called molded, can change the shape in the process of birth, and allowing the baby to be um, to go through the birth canal and come outside. And immediately after that, those bones are kind of reshaping themselves on their own, and they come back into place. They sit back into place. And those suture will start immediately after birth to close. We have what is called the posterior fontanella, this kind of gap in the back that closes by 3 months of age. And we have an anterior one, a bigger one, that will close by 1 year. Whenever those become, they're still open after 1 year of age, is usually a neurologic condition that needs to be addressed in that baby. Sinuses, and this is a representation of the sinuses that I was talking to you before, that we have them in different bones. We have the frontal sinuses, that they are at the level of your frontal bone, ethmoidal sinuses, and you can see here how the ethmoid bone sits behind the eye socket, and we have two of them. And we have the sphenoid sinus that is even more in the back, and you can see how it has inside of it will carry the pituitary gland, and it had this sella, this um, place where it's kind of a fossa where the pituitary gland sits in. And the biggest ones that we have will be our maxillary sinuses that are in the maxillary bone. Vertebral column, or the spine, has three main functions: to support the head and the trunk, provides for the flexibility that allows a wide range of movements because of the big amount of small joints and that connect all the parts of the spine, and they function together, allowing for this type of multiple type of movements. And they also form a passageway for the spine, the nervous system, the spinal cord, to connect to the brain. That space is called the vertebral canal. We have 7 vertebrae for the cervical area, with the first one on top of it called the atlas, and the second one called the axis. We also have at this level a structure at the level of the occipital bone that is called foramen magnum. It's a big hole inside the occipital bone, where the passageway from the spinal cord connects to the skull cavity. We have 12 thoracic vertebrae that have a more prominent transverse process. Those prominences, projections in the back, are more prominent at the level of the thoracic spine. We have 5 lumbar vertebrae. They are named L1 to L5. Forgot to say that for the thoracic vertebrae, they are named T1 to T12. We have 5 vertebrae for the sacral region, that they are separate in children and they become one body. They will fuse together in the process of maturation in adults. And we have 4 to 5 tiny bones that make up for the coccygeal vertebrae, that usually they are fused into one structure that is called the coccyx, or the tailbone. You can observe here that the spine is not a straight line structure, and it has a few curvatures. And we have a cervical one, and we have a thoracic one, and we have a lumbar one, and a pelvic one. And you can see that they go to opposite way. It goes in a like a snake will go. It's like a continuous S formation that allows for stability and will provide something else. It absorbs the shocks when we are moving, when we are walking. It makes our walk to be very smooth, and we don't look like robots when we are walking because of this structure. So we have all in all 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacrum, and 3, 4, and sometimes 5 for the coccyx. Every vertebrae will have a body that will connect with the body of the next one. In between them will be a cartilaginous, however, kind of fibrotic structure that is called a disc that will allow for absorption of shocks, so the two bony structure will not going to hit each other while in movement. And in the back, this body of the vertebra is an anterior part of it. The projection is anterior, while in the posterior part, we'll have the vertebral arch that is made out of the spinous process that is just in the middle. And we have those lateral processes in each vertebra. Now, each vertebra will also connect not only at the level of the body, but also at the level of what is called facet joints. And you can see how they fit each other on kind of in an angle. They are not straight horizontal, but they are a little bit oblique. And please observe this space that is made out at the level of connection between two vertebrae. Those are the spaces where the nerves are coming out, because in this canal, this is the spinal canal where the spinal cord passes through. So at those spaces that you can see on the lateral view of the vertebrae connected, the nerves will come out. Whenever a disc will prolapse, it will put pressure on the nerves. Whenever there will be ossification or over-ossification of those areas with bony prominences that will put pressure on the nerves, will have a pathology. And that's your typical way that sciatic injuries or pain starts, by discs that are prolapsing and putting pressure on a nerve. The thorax, we have 12 vertebrae that will each connect with one rib. However, if you really look into that, you can see that I have what is called true ribs, only 1 through 7. And we define a true rib, a rib that starts at the level of the vertebra and connects to the sternum. After the rib number 7, the rib number 8, 9, and 10, they do not connect to the sternum individually, but they connect first to rib number 7. So 8, 9, and 10 are called false ribs because they do not connect individually to the sternum, while 11 and 12 are called floating ribs and are those ribs that are not even completing the circle to the front of the body. There was at a certain point about 10 to 15 years ago, there was fashionable for celebrities to try and reshape their torso and try and make themselves look thinner, especially at the line of the waist, by removing those two ribs, 11 and 12. And I think that the most famous one that did that was Cher in the beginning of the 2000, I think, end of the 90s. Number 3 question, which bone forms the back and part of the base of the skull? And the options are parietal bone, temporal bone, occipital bone, and sphenoid bone. Occipital bone forms the back and part of the base of the skull. Parietal bone will make up for the top of the head, temporal bone is the side, and the sphenoid bone is the one that, if you remember, is inside the skull and makes for the base of the skull from the inside. Now I'm looking now at the bones. This is summarizing the bones of the upper division and lower division. When we are calling upper division, we are looking into the shoulder girdle that has 2 bones, and the upper extremity has from humerus to the phalanges, and the lower division will have the pelvis with the lower extremity from femur to phalanges. The pectoral girdle will be made out of 2 bones. We have the clavicle and the scapula. The clavicle connects to the manubrium, which is the upper part of the sternum, and to the acromion process, which is part of the scapula. So if you want to say it like this, the clavicle connects from the anterior part of the thoracic cavity to the posterior one where the scapula sits. Scapula, in addition, will connect through the glenoid cavity to the humerus. So at the level of the scapula, we have 3 joints. We have the glenohumeral, sternoclavicular, and acromioclavicular joints. Anatomy of the humerus will start at the proximal epiphysis, the area that will connect to the scapula. And we have, let's define a few structures. We have what is called the surgical neck, and you can see this area where from a bulky structure becomes a thinner one, and it's called the surgical neck because this is the area that most of the injuries will happen because it's a weak area. Every bone will fracture and will break wherever it is the weakest part of it. As opposed to that, we have the anatomical neck, and that's where actually head becomes the diaphysis. We have a few tubercles. We have the greater one where we have some muscles from the rotator cuff will have their insertions, and we have the lesser tubercle that will have the subscapular tendon inserting on it. We have another part that is called the deltoid tuberosity. Deltoid is the main muscle of the shoulder, and you can see how low actually the insertion of the main muscle of the shoulder is at this point kind of in the middle of the arm, and you can understand how important the deltoid is in lifting the arm because as a lever will action in the middle of it. When we look at the lower part or the distal epiphysis, we can see that we have a lateral condyle where it will be the connection with the radius, and you can see here both from the posterior view and anterior view, you can see one of them is the lateral condyle for the radius connection, and we'll have a medial one to connection with the ulna, with the other bone of the forearm. In the middle, we have what is called the coronoid fossa. That is the spacing between the 2 epicondyles. Radius and ulna, they will connect proximal to the humerus and distal to the carpal bones. You can see how they kind of overlap each other. This is an X-ray of the shoulder at the shoulder level. There are a lot of elements on those bones. I do not expect you to know all of them. They are here for your information and not more than that. What it's interesting to know about those bones is that the way that they interconnect with the humerus and with each other at those areas, those 2 points, allows for what is called pronation and supination, the rotation movement that we can do at the level of our forearm. And pronation is placing your palm down, while supination is placing your palm up. The best way that I can give you the best mnemonic to give you to remember the supination is that sup is like a bowl that you can make with your like a bowl that you can make with your palms to hold soup in it, as opposed to pronation that is laying down or face down. We are looking now at the wrist anatomy and the hand. We have the 8 carpal bones. I do not expect you to know all the names of them. They articulate with the 5 metacarpal bones, and we have the phalange. We have 2 of them for the thumb and 3 for each finger. They are named, the phalange are named proximal, middle, and distal. For the thumb, we have proximal and distal, and the joints are defined as proximal and distal interphalangeal joints. Pelvic bones, we have the pelvic arch that is made out of 3 bones. We have the ischium, ilium, and the pubic bone. You can see them a little bit better over here. So you have the ischium, the pubic bone, and the iliac bone. Lower extremity going from the proximal epiphysis down will have a head and neck, with most of the fracture happening at this level. After that, we have 2 protuberance. One is the greater and one is the lesser. Lesser means smaller trochanter with that are actually the main places of insertion for the thigh muscles. And on a distal epiphysis, we have a patellar surface that comes in touch with the patella at the level of the knee, with a medial and a lateral condyle. Tibia and fibula, that are the bones of the leg, will be also connected, just like the ulna and radius are, allowing for a more limited type of twisting at the level of the foot, but still existent. Will connect proximal with the femur and distal to the ankle. The foot itself will have the bones of the ankle. There are 7 tarsal bones. Probably the most common one that you will probably need to know the name is called calcaneus, and that's the heel bone. And after that, we have 5 metatarsal bones. In order to remember, you have carpal for the hand and tarsal for the foot. You have metacarpal for the hand and metatarsal for the foot. And we'll have the phalanges that are 2 for the first toe, second, third, and fourth toe. Will have 3 phalanges. Also defined, just like in the hand, is distal, middle, and like proximal, middle, and distal. Question number 4. Which of the following bones is found in the shoulder girdle? And the options are sternum, humerus, scapula, and ulna. Scapula is the bone found in the shoulder girdle. Sternum is part of the thorax. The humerus and ulna are part of the upper limb. Disorders of the bones can be classified as metabolic, tumors, infections, and structural problems. And we'll discuss each of those. So inside the metabolic disorders of the bone, whenever there is a lack of calcium in the bone structure, we call that osteopenia. However, when the lack of calcium becomes severe and the structure of the bone becomes porous and fragile, we call that condition osteoporosis, and it's typical mainly for female at menopause or postmenopausal. However, it can be seen in male too, and it's usually associated with low level of testosterone. So from this, we understand that calcium deposits and the usage of calcium is highly related to the level of hormones in our body as estrogen and testosterone. This condition will predispose the patients to fractures, especially for those bones that are weight-bearing bones or long bones. We'll see fractures in osteoporotic patients in the pelvic bones, their femurs or humerus will be prone to fractures, to injuries, even to low velocity ones. The treatment is hormonal replacement therapy that will improve the deposits of calcium, definitely with supplements of calcium and vitamin D. Another type of metabolic disorder will be osteitis deformans, and this is the result from excessive and sometimes abnormal osteoclast activity. And as a result of this excessive osteoclast activity, we have excessive osteoblast activity in response to that. And as a result of that, we'll have areas where the bone will have high quantities of bone tissue deposits as opposed to other areas that will be depleted of the bone structure. So the cause for osteitis deformans is also called the Paget disease, and the cause for it is not certain. It is believed that there is a mutation in the genes that will regulate the osteoclast activities. Osteomalacia is a condition where the bone tissue will become soft, and the result the cause for the softness in the bone is a lack of calcium salts deposits. You may say that is kind of a variation of osteopenia or osteoporosis. It's typically seen in vitamin D deficiency cases or as rickets in children. So if osteopenia and osteoporosis is mainly in elderly, when we see the same condition in younger individual, we'll call it osteomalacia. Osteogenesis imperfecta, it's a genetic disorder and is the result of production of defective collagen. And as a result of that, the ossification of this matrix will be defective also. This picture will show you this is normal spongious bone, and you can see how many trabeculae there are in here, and that's kind of a very dense structure as opposed to this one, that this is an osteoporotic bone, typical one, and you can see how it lacks the structures that will be able to support and will not be resistant as the same way that the normal tissue is. You have here the examples of the Paget disease with hyperdeposits of bone, and you can see those spines coming out. Those are bony structures that are not supposed to be here. We have the rickets here, and typical for the rickets will be this kind of bow legs. We do not see a lot of rickets in the now in the modern time, especially when everything is all the formula for babies is reinforced with vitamin D and calcium. Bread, even if you look at it, you'll see that it's reinforced with calcium and vitamin D. The milk that you're buying in the supermarket is also reinforced to prevent those conditions. So from this point of view, I do not think that we see rickets anymore in the pediatric population. You can see a typical picture here of the osteogenesis imperfecta or the glass bones. You can see how they are kind of clear bones. They look like glass, and they are very brittle. Those patients suffer from recurrent fractures everywhere, and sometimes those fractures can be even without trauma. Just by making a sudden movement, the muscles are stronger than the bones and will break the bones. Um, Regarding bone tumors, um, we'll see both benign and malignant type of tumors in the bone tissue. When it's a benign tumor, it's called an osteoma, and it's a cyst type of tumor. The malignant ones are two types. They can be osteosarcomas when they start at the level of the bone cells, or the chondrosarcomas when they start in the cartilage cells. They are highly aggressive. They usually happen in young patients and have um, very high rates of metastasis, and they are evolving rapidly. A lot of times, the treatment needs to be completely radical, up to amputation of the limb. Most of the time, the limb they show up on the appendicular skeleton, and it's very hard to save that part of the body. Osteomyelitis is, your book said that it's an inflammation, but it's in fact an infection. Um, every infection is a type of inflammation, but osteomyelitis is, per definition, an infection with what is called a pyogenic bacteria. Pyo means pus, and genic or genesis means producing. So pus-producing bacteria will cause osteomyelitis, and usually they are from the staph family, Staph aureus, that we usually have them on our skin. And the organisms will reach the bone either through the bloodstream, through the blood vessels, or after an injury from the penetration of the skin. If you remember, I was telling you about the compound fractures that the bacteria can get inside to the level of the bone. Usually the infection is localized. However, it may spread out and generalize to other structures around the bone. The treatment is usually very long. The patients need antibiotics for a long period of time. And you can see in the image on the right side of the slide, you can see different stages of an infection, of an osteomyelitis of the first toe. And you can see how the phalange, not only how important is the swelling of the toe, and you can see how progressively is improving, but you can see here in the picture how the bone tissue is completely destroyed and how slowly becomes to recover in time until it recovers completely. But you can see that after recovering, it looks like a monstrous kind of tissue. Every tissue that repairs itself, it has a certain component of scar. Even bones will show that, and will not going to be the same as before. Tuberculosis is another type of infection of the bone. Whenever it's localized at the level of the spine, it's called the pot disease. As a result of infection and this destruction of the bone tissue, like you see that it happens in this picture, the vertebrae may collapse, and you can see in this CT scan how dangerous this is for the spinal cord, because it can, when they collapse on each other, they can literally section the spinal cord, and the patient may become paralyzed as a result of that. Structural disorders. Um, First of all, we look at the spine, and we do have the normal curvatures of the spine. However, when they are accentuated more than necessary, they become a structural disorder. And you can see here, one type is the accentuation of the thoracic curvature, and it's called kyphosis, or the hunchback. Whenever, and this is seen a lot in osteoporotic patients, especially in elderly. They do have this kind of hunchback at a certain point. We do have what is called a lordosis. That's an accentuation of the lumbar curvature. or a sway back. And this is typical and it's normal in pregnant female towards the end of the pregnancy. And we have another type of structural disorder when the spine is sideways, becomes having an unnatural curvature when it's supposed to be a straight line, and this is called a scoliosis. Another type of structural disorder will be the cleft palate. Um, and we are giving you only examples of types of structural disorders of the bones. When we'll do typical disorders during the program of the musculoskeletal system, you'll see that there are way more other types. Whenever the palatine bones are not connecting with each other during the embryologic development as a fetus, the condition is called the cleft palate, and there is a direct communication between the oral cavity and the nasal cavity, because this area, the mouth roof, is supposed to separate those two cavities. Another type of structural disorders of the bones would be your flat foot, and there are a whole other range of structural disorders. How fracture heals. As this, I was describing this at the beginning of the lecture, and I was telling you that a blood clot will form around the fracture, and along with that, because the blood vessels are injured and will bleed inside the area of the fracture, will develop also a clot, because they are bringing with them all the elements that are contributing into clotting and healing. Together with clotting elements, fibroblasts will invade that area and will start secreting collagen. A little bit later, the macrophage will start removing that blood clot, while the osteoclasts will resorb the dead bone tissue, and the osteoblasts will start converting the soft callus into hard callus by depositing calcium salts. Um, at the end of the process, the osteoclast and osteoblast will remodel the whole hard callus into the compact bone. Especially the remodeling process will continue for a long time, for month and month after the healing of the fracture, and will be determined by the weight-bearing processes, and will be done along the lines of the force that is actioning on the bone. Joints or articulation um, are representing the areas of junction or union between two or more bones. And usually we classify them by the degree of motion. We have the immovable joints, that they are the synarthrosis. They are fibrotic type of joints, and typical for that would be the sutures in the skull bones. We have those that are slightly movable. They are called amphiarthrosis. In those type of joints, there is no joint cavity. There is a cartilage or some type of fibrous tissue that is interposed between the bones, and as a best example that I can give you is the pubic symphysis and the joints between the vertebrae. And those that are freely movable, they are called diarthrotic and will have a joint cavity, um, will be present some type of synovial fluid that allows for a reduced friction between the bones, and will be the rest of the joints in our body. And on themselves, they can be classified in smaller groups. So let's look how do we what is the subclassification of the synovial joints. The synovial joints, beside the fact that they will have the synovial fluid that allows for the lubrication, will contain a bursa, or they're a sac-like structure. And we have the classification of the synovial joints will be based on their degree of movement. Those with the widest range of movement are called ball and socket. Those will be the hip and humerus joint. The gliding type will allow for twisting and side-to-side movements, as in carpal and tarsal joints. We have another type that is a hinge type of joint that allows for extension and flexion, as in the elbow and knee joint. Another type of synovial joint is the pivot one that allows of movement in only one plane. Let's say like in the movements in between the ulna and radius. And we have the saddle type of joint that has a concave convex surface that they fit to each other. And it's the typical joint that is a saddle one is the one for the thumb. We'll discuss now a little bit of terminology to be able to have a common language when we talk about movements. Abduction, similar to abducting someone, taking someone away, it means moving a body part away from the midline, with adduction, adding to, ADD, moving a body part toward the midline of the body. The circumduction will be a movement of a particular part of the body in a circular way. In a circumduction, however, we are not moving the entire body part. It's like moving a finger in a circular motion without moving the hand, and those that are playing a lot of console games, they know what I'm talking about. The rotation is moving a body part around the central axis. It's like rotating the body, your whole trunk around an axis that goes through the middle of your body. Dorsiflexion. As an example of dorsiflexion will be the bending the foot upward at the ankle joint, while plantar flexion is just the opposite movement, bending the foot downward at the ankle joint, just like the ballerinas will do. Eversion motion is turning the foot outward or inside out at the ankle joint. So as a result of that, the sole of the foot is shown outward. And the inversion is turning the foot outward at the ankle joint, and the sole of your foot will point inward. A lot of our joints will allow for flexion, which is like complete bending of that joint. The two elements of that joint will bend and flex together, and extension is straightening of that joint. Pronation and supination, those are the two opposite movements. I was explaining to you that supination is pointing a body part upward, like turning your palms up, facing the palm upward, like holding a bowl of soup, and pronation is pointing that body part downward. Again, you can see here abduction away, adduction inward, back, close to the midline of the body. Circumduction is rotating in circles. Flexion, extension with the hyperextension in the back. Dorsiflexion or plantar flexion. Inversion, eversion, pronation, and supination. Let's take a look very quick at disorders of the joints. Um, joints, most of the time, will be affected by mechanical or stress disorders. Um, and probably the most common one would be a dislocation. And in a dislocation, there is a derangement of the bones that are supposed to face each other in the joint. Usually it's very common in ball and socket joints. Humeral dislocation is probably the most common pathology seen out there. And sometimes some patients may come with what is called recurrent dislocations because that joint becomes so lax, so flexible that it will go in and out and will not gonna keep the two surfaces together in the way that they should be. A sprain is what it's called a wrenching of a joint, and usually there are ruptures or tearing of the ligaments, and they are the result of an excessive movement. It's whenever you make a wrong step and you sprain an ankle or a knee. Those ruptures can be full ruptures or micro ruptures. Usually, again, the most common one is the ankle. As a clinical picture, you will see pain and swelling that will be easily treated with just ice packs and rest. Bursitis are inflammations of a bursa, of the ligaments and the joint capsule in a certain area in one joint. And usually they are very painful. They come with swelling, and there is a limitation in motion. And there are some bursitis that are more common, as olecranon 1, olecranon bursitis at the level of the elbow. And usually this is causing those people that are leaning on their elbows a lot when they are studying. Ischial bursitis is at the level of the ischium. It's common in people that are sitting for a very long time, like truck drivers. Another type will be the prepatellar bursitis. That's the inflammation in between the patella and the knee joint. And usually is that it's a condition that was back in the day called the housemaid knee. It was seen in those people that were kneeling a lot. Back in the day, housemaids used to kneel down and scrub the floors, and that's how that bursitis showed up. Bunions. Bunions are in fact enlargements enlargements of the bone that they are found at the base and the medial side of the great toe. Um, and they develop as a prolonged pressure on that side of the joint. Vertebral disorders, probably the most common one is the herniation of the discs. In between the vertebrae, we have that fibrotic structure that may go through a degenerative condition and may slide out and put pressure on the nerves that are coming out, like spinal nerves that are coming out in between two vertebrae. Arthritis, it's a general term. It means inflammation of the joint. Remember that itis means inflammation, regardless what is the prefix, what or the root of the word is. Itis means inflammation. And inside these big categories, some of the arthritis are just inflammations as autoimmune inflammation, while others can be infectious. Osteoarthritis is also called the degenerative joint disease, is very common in elderly, and is a result of the normal wear and tear at the level of the joints. As a result of that, the cartilage that covers the two sides, both bones that needs to come in contact, will be destroyed, and we end up having functioning and wear and tear of bone on bone that is associated with a lot of pain. Rheumatoid arthritis, It's an autoimmune disease. It's an inflammatory disease that has as a hallmark joint swelling, mainly at the hands, but it can happen at the feet. And in association with that, we see an overgrowth of the synovial membranes in those tissues. In this one, we'll have articular cartilage, also destruction of this articular cartilage. And inside the joint cavity, they will develop what is called adhesions, or kind of membranes that will attach structures that are not supposed to be attached together. The treatment for those conditions are anti-inflammatory and corticosteroids. Septic or infectious arthritis is usually caused by an infectious germ like Streptococcus or Staphylococcus. Also, for joints specifically, there is another one that is called Neisseria that can cause a lot of the infections. The treatment is pure antibiotic, and for everything that is related, every type of infectious disease that is related to bone and joints, the treatments need to be very long. Gout it's in fact a metabolic disorder, and it's a result of accumulation of uric acid in the body that is not normally excreted in urine, and those crystals of uric acid will get, because it's an overwhelming quantity in blood, will become deposited in the joints, especially at the level of the big toe in the foot. And this condition comes with exacerbations of pain and swelling and redness and lack of capability for the patient to walk. You can see here how a herniated disc puts pressure on the spinal nerve on this side, as opposed to this one where the nerve is not affected. This is your typical sciatic nerve inflammation picture. Osteoarthritis, where you can see the wear and tear at the surfaces that usually need to come in contact, and it's bone on bone wear and tear at a certain point. What will be some treatments that we can do? Back in the day, we used to do the procedures to repair joints by performing open procedures. That could be very big because a joint is to get to a joint, you need to perform a wide incision. Nowadays, we have what is called an arthroscopy, or minimally invasive procedures, where we can clean cartilages that are damaged. We can restore functionality of ligaments, completely reconstructing ligaments. We can, if there is an infection, we can wash out the infection and instill in that joint antibiotics. So question number 5, freely movable joints are also called fibrous joints or cartilaginous joints, diarthrosis or amphiarthrosis. The answer is diarthrosis. The freely movable joints are diarthrosis. With aging, you by now kind of heard a lot of things that happen with aging, and the most important change with aging is related to the fact that this is a connective tissue, and there is loss of calcium salts with a decreased ability to form the matrix that will efficiently deposit the calcium salts because an impaired secretion and synthesis of collagen. Along with other tissues and other structures in our body, the cellular metabolism will become slower. As a result of lack of calcium, the bones become weaker, more fragile, and the patient will be predisposed to fractures or any other type of muscle injuries. As a result of changing in the bone structure and the overall dehydration of the body with aging, the vertebral column will lose in height. Usually we lose about half an inch every 20 years starting in our 40s. we are kind of shrinking. At the level of the joints, the cartilage that covers the epiphysis will become thinner and thinner with aging, and there will be a decreased flexibility at the level of the joints as a result of aging and overall dehydration of the body.